managing pediatric cataract is a big challenge, though we all have basic requirements like general anesthesia, good setup of equipment or instruments, good biometry machine, efficient theater team, and your own expertise. But still, decision making is very, very challenging in pediatric cataract surgery. Like the decisions making basically depends on age of the patient, the cataract, morphology, associated structural abnormalities, and laterality. And the decisions we have to make are on type of surgery with or without PPC, with anterior vitrectomy, intraocular lens, now or later, or types of IOL, which one, bag or sulcus or iris fixated, scleral fixated, and target post-operative refractions, visual rehabilitation. So these are some of the things that we have to make decisions on in pediatric cataract surgery. And then the challenges increases when the cataracts are complex, like traumatic cataracts, inflammatory cataracts, subluxated cataracts, pre-existing posterior capsular defects, cataract with glaucoma, PFV, unilateral cataracts, microcornea, and there are many more. The list is more. So now I'll talk a little bit on how we manage some of the difficult cataract situations. Like in traumatic cataracts, it ranges from minor blunt trauma to a very complicated fibrotic cataract. So in blunt trauma, the cataract can be from sunflower to liquefied white cataract, synecdoche, angle recession, associated inflammations, thick fibrotic capsule, liquefied vitreous, vitreous inflammation, old hemorrhages, retinal detachment. All these are associated with our traumatic cataract. And in penetrating or perforating, the things become even more complex, like it ranges from small peripheral corneal opacities to ruptured anterior and posterior capsule, thick fibrotic bands and retinal detachment. Any or all other layers of the eye may be involved. And surgery becomes difficult when the capsule is thick fibrotic adhesions, iris injuries, and lens trauma. So, and then again the challenge, the timing of the surgery, when to do the traumatic pediatric cataract surgery. So if there is a long wait, then chance of amblyopia. If the early surgery, then there is a chance of more inflammation. So wait for at least 6 weeks, suture remove, and at the time of the 6 weeks, what we can do is we can remove the suture, cataract extraction, and the IOL placement can be done in the same sitting, because in children, in almost every time, the general anesthesia always comes first. So that's why that is also poses a risk. And we can start with the short-term corticosteroid, oral corticosteroids usually needed in traumatic cataracts. Long-term follow-up is required, and close follow-up for chance of glaucoma or other vitreoretinopathies. And another one is inflammatory cataract. The cataract and uveitis, careful anti-inflammatory, at least for 6 months free of inflammations, and endophthalmitis, wait for 6 months. Blunt trauma with inflammations, wait for at least 3 months under the cover of steroid, and post-operative medications is very, very should be carefully given. And like another complications associated cataract after the trauma is post-RD surgery, penetrating keratoplasty, trabeculotomy. So these are some of the important very challenging pediatric cataracts associated with other diseases. And then another challenge is the subluxated lens. If there is a large subluxations more than 180 degrees, then always lensectomy and anterior vitrectomy. And scleral fixation IOL should be done in older children only. And another option is the iris claw lenses, the glasses or contact lenses, and smaller subluxation CTR can be put with the intraocular lens. Then the microcornea. The cornea usually is not healthy, so chance of post-operative hazy cornea and corneal edema is always there in cases of microcornea. The IOL, smaller IOL, if available, can be given, and studies shows the good surgical outcome. No IOL in severe microcornea, and FEK glasses or contact lenses. And sometimes difficult to dilate pupils are also sometimes becomes a challenge, and intracameral adrenaline can be used in those cases. And pre-operative planning is very much important in cataracts. Complex cataract is always associated with ocular anomalies, so very important to identify those anomalies. Ultrasound, B-scan, and place for IOL placement, whether there is intact bag is present or not, sulcus is present or not, and that also makes the decision of which IOL to put. So I'll show some of the videos, short videos, in some managing complex pediatric cataract cases. This was a cataract with the trauma. So we come across all these difficult situations in our practice. And there was a big cataract with a big corneal scar and with a thick fibrotic membrane. And so cataract was removed, and then the IOL, the PMMA IOL was put in this case with a small scleral tunnel, and the lens was kept in sulcus. So whenever we have to put lens in the sulcus, for us there's few options. One is PMMA, the another one is 3-piece foldable IOLs, and the another one is the tetra lenses, that is one piece but still they have very good fixation. And there is another one, this is an inflammatory cataract. So these type of cataract also poses a big challenge, and the synechiolisis was done, and then the cataract was removed with the bimanual vitrectomy cannula probe. And then so whenever, sometimes if the pupil is difficult to dilate, then the synechiolisis can help a lot in doing that. And in this case, the foldable IOL was kept in the bag. The one-piece foldable IOL was kept in the bag, and then the vitrectomy was done after going through the limbal approach, going behind the lens. And then this is the cataract with a pre-existing posterior capsular defect. Sometimes we come across this, and in these situations we have to be very careful because there is always a large defect in the posterior capsule, so the cortical matter may go into the vitreous and the eye becomes very soft. So in these situations, the bimanual vitrector helps a lot, because the vitreous that comes along during the process can be easily taken out with the vitrectomy cutter that is always in your hand. And you can see there is a big already pre-existing defect. So I'm putting the tetra lens here in the sulcus. This is a very good and having a very good fixation in the sulcus. So I'm putting this sulcus fixated lens in this child, and then since it was already the pre-existing defect with the vitrectomy already done, so we don't need to do that again. And then another one is the membranous cataract, in which there is no anterior and posterior, the anterior posterior capsule is fused and there is no proper bag. But in this situation also, you can just use the vitrectomy cutter and then remove everything in a one go. So it's very easy. Then another one is, I just wanted to show sometimes in pediatric cataract, it becomes very difficult to dilate the pupil, and putting the pupillary stretcher is also very challenging. So I always try ask our anesthesia colleague for the adrenaline, diluted adrenaline, and then that saves me for all the complications. So putting iris hook and pupil stretch is also very challenging in smaller children, because you have to put sutures and all. And another one is the blunt trauma with the white cataract. This one was this again, there's white cataract, and we don't know the integrity of the capsule, posterior capsule. So in this situation also, it becomes challenging, and what is there inside you don't know. So though the B scan can give you some clue, but still whether the capsule is intact or not, whether there is fibrotic plaque or anything. So in this case, there was a thick fibrotic plaque on the posterior capsule after the removal of the lens matter. I put the lens inside, the tetra lens again in this case, because the anterior and posterior capsule was fused and there was no proper bag, capsular bag. So I just put the lens in the sulcus and then after that, behind the lens, I did the posterior capsulotomy and removing the plug. And this was a very, very severe traumatic cataract. Sometimes we get these type of cases, so leaving them just is sometimes we can do at least try something to make that visual axis clear. So at least if the posterior part is intact, posterior segment is good, then the child can have some amount of vision. So in this situation, in this type of situation also, we can at least clear the visual axis. And sometimes the intraocular seizures has to be used in these situations. Only the cutter cannot open the thick fibrotic capsule. So this is another very severe traumatic cataract case with a thick corneal scar, and then with the use of cutter and scissor, we could at least clear the visual axis in this case. And we can always prescribe the aphakic corrections. So these are some of the cases, and complicated cataract always pose a big challenge, and management requires a holistic approach with all the subspecialty involved. And bimanual vitrectomy in these situations is a very wonderful tool. And but at the same time, we have to give a good parental and patient counseling, because pediatric cataract is not a one hit and go thing. It has to be a long-term follow-up, and rehabilitation is involved. And timing of surgery and IOL implantations depends on individual cases and surgeon's clinical judgment. Thank you so much for the.
We'll take questions at the end of the session. Next, I will call Dr. Sanyam Bajimaya, who will be talking about management of retinal detachment after VR procedures. Dr. Sanyam Bajimaya.
Thank you, AIOS, and thank you, Ava ma'am and chairpersons. I'm presenting on management of retinal detachment after primary VR procedure. I do not have any financial disclosure. Recommended retinal detachment, the incidence is 6.3 to 17.9 per thousand. And in our Asian populations also, the myopia and is one of the factors where we are getting more detachments. Cataract surgery, post-cataract, if there is any complications, even simple cataract surgery is also one of the risk factors for retinal detachment, which induces posterior detachment and subsequent consequence of retinal tear. And if there is any history of trauma and family history. So there's a rising trend of myopic retinal detachment in Southeast Asian and South Asian countries. So when we come to the management, one of the most important thing is the detachment patients, 50% will never get happy. So we need to have a very adequate counseling. We need to have a very good documentation from our side, including all paperwork, black and white documentations, fundus photography, ultrasound. So this is really, sometimes we get into the legal problems. So we need to have a proper recording systems and EMR, medical recording system. And also there are options like pneumatic vitrectomy, so pneumatic retinopexis, buccal vitrectomy, and combined surgeries. So many options are there, but sometimes I will come across the case directly to one of my clinical case back in 2021. She's a 65 years old female, and she is diabetic, and she is hypertensive, and she was on blood thinner. And she had a history of blurring of vision in both eye, and when we did a retinoscopy, she was wearing a very high myopic glasses on, and she had these issues of diabetic macular edema, both subretinal and intraretinal fluids, and there was a traction, which is called as vitreomacular traction. So with this, seeing this scan, then we first try 2 doses of injection Avastin. So after injections, the swelling and the macular volume slightly reduced, but the traction was persistent. And since he was 60 plus and having some cataract, so we planned for doing cataract surgery. And we combined the cataract surgery with pneumatic vitreolysis. That is, at the end of the surgery, we inject a 0.3 ml of 100% of C3F8 gas. So this surgery has been done for her right eye, where there is an extensive vitreomacular traction, even though the diabetic macular edema has been reduced. So this was a cataract surgery, so I will slightly fast the surgery. We implanted the Alcon IQ lens, and we injected 0.3 ml C3F8 gas, and lastly, intracameral moxifloxacin. So this was a macular OCT after cataract surgery and pneumatic vitreolysis. The VMT is completely gone, and the situation you can notice what was there. In the inferior temporal, in the fundus photo, there's a detachment. So 1 month, though we are happy with the VMTS, but there's a detachment inferior temporally with macula on 6/9 vision. So in such a case, we have two options, whether going for buccal or vitrectomy. So what we did is we planned for buccal surgery. Sorry, we planned for vitrectomy. Three-port past minor vitrectomy. So this was June 2022, and we did a 23 days past minor vitrectomy. And this is just 1 month old post-cataract surgery. And it's very important to counsel the patient because she's a myopic. And the gas inside the vitreous that probably had led to extension of the peripheral vitreous detachment after the VMTS release. So there must be some peripheral tear or holes. So that led to the inferior temporal retinal detachment. And PVD is very important. I did a posterior vitreous detachment in peripapillary area first, with leaving behind the, with a very meticulous protection of macula, since there was already a traction before. So this was a vitrectomy, peripheral vitrectomy, and I checked there was a holes in inferior temporal area, and after the vitreous, meticulous peripheral vitreous saving, and since she's a diabetic also, so I would go for a near complete vitrectomy. Let's not leave any vitreous. So peripheral with indented, scleral indented vitrectomy has been done. So I identified the holes, marked it, and checked peripheral retina as well till ora serrata. So this is so important to have a peripheral vitrectomy in the high myopic patient as well as his diabetic. So it's so important to do a very, very complete vitrectomy. So this is almost towards the complete. We can see some very small holes on the peripheral retina, a very far periphery, and this was the small and next hole, which was on the attached retina. So we drain it from the equatorial region with making a retinotome, and we remove the subretinal fluid under fluid error exchange, and did endolaser retinopexy, and we kept a C3F8 gas. Though it is inferior temporal retinal detachment, we didn't prefer putting silicone oil. So though inferior detachment, we still kept 20% of C3F8 gas and requested patient to have a complete 7 days face down, if possible more face down, moving forward the head for forehead. So even inferior detachment, we don't go for silicone oil, so gas also works very well. And 3 months, he had an attached retina. Visual acuity improved 6/12, and in the left eye, he's still myopic. As he was a high myopic, so our plan was to left eye cataract surgery in the near future. So when we come to the pneumatic vitrolysis.
So actually this has been used very commonly for VMTs or other vitreomacular adhesions syndromes, especially
When there is a stage 2 macular hole. This really works. Almost 86%, one of the studies, 86% of treated eyes had a PVD detachment on VMTS, and closure of small macular hole stage 2. But when it comes to the DRCR.net on protocol EZ and AH, where they have utilized SAM and injections of C3 gas, there was higher incidence of retinal detachment following iatrogenic, the augmented PVD tear. So the study was stopped in between, like 8 to 9 months later, because of more complications of pneumatic vitrolysis for the cases of diabetic VMTS. So the study was terminated and concluded that let's not go for pneumatic for diabetic VMTS. So this was a case 2. He's a 61 years old patient, and he's a non-diabetic and hypertensive, and had a history of vision blurred in left eye. His visual acuity is just hand movement in the left eye. A patient is also myopic, and he had a history of vitrectomy in the other center before coming to us. When he came to us, it was a complete vitreous hemorrhage, very suspected retinal detachment. So we planned for, since there is a total vitreous hemorrhage, after somewhere he had a vitrectomy, so I have to do it as early as possible. And this kind of vitreous hemorrhage with suspected detachment, I shouldn't wait. So I did he also had some amount of cataract. So I planned for left eye cataract surgery. So usually whenever I see a cataract, even nucleus 1 or PSC1, so I prefer doing cataract. See, patient already had an NS2 and cortical 2, so I planned for cataract surgeries combined with pars plana, 25 gauge pars plana vitrectomy. So to my surprise, when I removed all the central the vitreous hemorrhage, so I could see the retina was detached, definitely. So my suspicion came true. So the detachment was temporal with a giant retinal tear, and so I prefer putting a heavy liquid PFCL. So this porphyrocarbon liquid is really helpful for whenever there is a large giant retinal tear detachment. And then I do the fluid erections, and I move to 23 gauge for the endo laser. So very nicely, I've done fluid erections under the heavy liquid, and we injected silicon oil. So this case also very important for learning, because he had a very good attachment for almost a month, but after then we also add laser. He underwent post-operative very smoothly, but after 10 weeks, nearly 2.5 months later, so we see his refraction came to be 6/660 with +10 under silicon oil. So everything was fine. Then we planned for silicon oil removal and vitreous wash. So after 3 months, exactly from the first our intervention, we did a vitrectomy, vitreous wash, silicon oil removal, and secondary intraocular lens implant. So vision was improved to minimal improvement, but later at 6 weeks, he again developed vitreous hemorrhage. So the hemorrhage was probably this time when we did the vitrectomy and vitreous wash, we found that there was some ischemic and some new vessels as well. So we've planned for, again, injections of Avastin for this case. So vitrectomy, vitreous wash, and fluid erections. So his vision came to be 6/60 after this, my second interventions. So again, after 4 months of the silicon oil removal time, he again developed vitreous hemorrhage. So this time, the patient must be very unhappy, and he must be blaming to us. So I saw that his blood pressure was very high, and he had a complete total vitreous hemorrhage. So I did ultrasound, but there was no detachment. So, but then still, in such a case, when there is a hand movement total vitreous hemorrhage, then I have to go for, again, redo the surgery, and let's see what is being inside. So this is a 4th time, including the elsewhere who has done surgery. So this is 4th episode we are doing surgery on his retina. So this time, even after the secondary eye implantations, so we could see there's a retina was completely attached. So there was some bleeding vessels. Then we cauterized and we
Sanyam, you need to wrap up.
Yes,
Time is up,
CT-effect gas, and we did a 360-degree barrage endo laser. So this case also came to be very fruitful, and after the 4th intervention, he had a very quiet eye. So my conclusion to the presentation is pneumatic vitriolysis can be a primary VR intervention for VMTS and stage 2 macular hole, but there is a higher retinal detachment and retinal tears for diabetic VMTS, and adequate evaluation and meticulous vitrectomy for detachment management is mandatory. Thank you so much. Thank you for your patience.
Thank you, Dr. Sanyam. Now I will call upon Dr. Ranju Kharel, who will be speaking on specular microscopy, ideocorneal angle. Can they be the biomarkers in managing anterior uveitis?
Thank you, AIOC and Nepal Ophthalmic Society for this opportunity. So I'll be talking on specular microscopy, ideocorneal angle, and corrected intraocular pressure. Can they be the biomarkers in managing anterior uveitis? I have no important disclosures to be made. So I start that globally we all know anterior uveitis is the most common anatomical form of uveitis. It is true for our country also, where 61.8% of all uveitis fall under the anterior uveitis category. And what happens basically is, in case of anterior uveitis, there is breach in blood aqueous barrier. This leads to the release of inflammatory mediators and exudates in the anterior chamber. This interrupts the normal function of the corneal endothelium, the trabecular mesewalk. There is some insult in the ciliary body and also in the aqueous humor. So when there is breach and release of these mediators and exudates in the anterior chamber, there is the presence of these keratic precipitates in the endothelium. This leads to the alteration of the endothelial cell dysfunctions, alteration in the corneal thickness. If the keratic precipitates are very large, they go near the angle and they can obstruct the normal drainage pathway and then thereby alter the intraocular pressure. What next? The cells in the anterior chamber, the exudates and hypopyon, they can have a direct impact to the endothelial cornea, corneal endothelial cells, or they can clog at the angle, causing the outflow obstruction. Moreover, these inflammatory mediators can lead to the thickening of the iris and also the trabecular mesewalk, thus leading to the structural change. Thereby, there can be change in the pressure. The intraocular pressure can be elevated, and this can happen because of the resistance in the trabecular outflow, which is due to the trabeculitis or the morphological changes in the trabecular mesewalk causing the narrowing and decreased drainage, or because of the occlusion. Not only that, there can be reduction in the intraocular pressure, which could be due to the increased uvascleral outflow. The inflammation in the ciliary body can also lead to the reduced intraocular pressure, leading to hyposecretion due to ciliary shutdown or even because of the ciliary body detachment. And the final thing is the presence of the 360-degree posterior synechiae causing occlusive pupillae can lead to the secondary blockage, or the peripheral anterior synechiae can lead to the narrowing of the angle. So this all can lead to the change in the intraocular pressure. So we did some hospital-based comparative cross-sectional studies at the eye department of BP Koirala Alliance Center for Ophthalmic Studies, where we looked at the affected eye as the case eye and the unaffected fellow eye as the control eye in cases of unilateral anterior uveitis. But in case of bilateral uveitis, we took the control eye as the eye of the healthy people. And then, which were the biomarkers that we looked for? There were 3 biomarkers. The first biomarker was the endothelial cell density, which was evaluated by specular microscopy using the Nidec machine. Here we found that the corneal thickness, when there is endothelial dysfunction in the affected eye, the endothelial counts goes down, and this leads to the increase in the corneal thickness. So this is a representative picture where we can see that the endothelial count has gone down because this is a case of right eye acute anterior uveitis. The count is low and the corneal thickness has increased. The next biomarker that we looked into was the ideocorneal angle. This can be assessed using the Bond-Cyrus corneal topographer, where it assesses the 360-degree angle in the angle and then gives an average of angle, ideocorneal angle, and it can separately gives the measurement of the angle in the temporal as well as the nasal end. So here we can see that the angle was narrow in the nasal part of this patient. It was only 34 degree at the time of presentation, which later reverted after the treatment. So third biomarker that we looked is the corrected intraocular pressure. What do we mean by corrected intraocular pressure? We all know intraocular pressure depends upon the corneal thickness. So with this Bond-Cyrus machine, we can have a corneal topography, and it gives the average measurement of the corneal thickness. And this machine has an inbuilt formula, Ehler formula. So inserting that with the use of this value of this central corneal thickness, it calculates by itself the corrected intraocular pressure. This patient had a pressure of 10 millimeter of mercury, but once we inserted the central corneal thickness of this patient, the corrected intraocular pressure came to be 8.04. So it was a false high pressure, and in fact this patient was having a lower pressure. So when we evaluated this parameters, these biomarkers, we found that the corneal thickness, the central corneal thickness in the eye at the time of presentation is definitely raised compared to the control eye, and that normalizes after the treatment. This is similar with the intraocular pressure, but there is only modest change in a normal intraocular pressure. But when we look at the corrected intraocular pressure, yes, the change is notable change in the pressure before and after treatment in compared to the control eye. There was also changes noted in the iridocorneal angle in the affected eye versus the unaffected eye, and also in the same eye before and after treatment. So when we analyze these parameters in the same eye, we found that the change in the central corneal thickness before and after in the same eye was statistically significant. It was significant, but not statistically in terms of intraocular pressure. But when we use this Ehler formula and calculate the corrected intraocular pressure, yes, the change was significant enough. There was change in the iridocorneal angle before and after treatment in the same eye, but it was not that statistically significant. When we compare this parameter, when we compare the central corneal thickness with the unaffected eye and the healthy control, we also found a similar value. It was statistically different compared to the other eye or compared to the healthy eye of the healthy person. Hence, what lessons did we learn was, yes, the specular microscopy, the iridocorneal angle, and the corrected intraocular pressure, they could be the markers in managing anterior uveitis, because we all know the increased corneal thickness is an indicator of endothelial dysfunction, which is shown by the altered endothelial count and the change in the hexagonicity. When there is failure in the endothelium, this leads to the corneal hydration. This causes the increase in the corneal thickness, but that corneal thickness reverses and come back to its state after the treatment. Hence, the endothelial cell count and the central corneal thickness can be an essential biomarker to assess the progression and treatment outcome in cases of acute anterior uveitis. Similarly, for the corrected intraocular pressure, we all know that the standard technique for intraocular pressure measurement is the Goldmann applanation tonometry. But this is standard only if the corneal thickness is 520 micron, because that's a normal CCT in a general population. If there is change in the normal corneal thickness, that is an average error of 0.7 millimeter per 10 micron deviation can occur if there is a change in the corneal thickness. Hence, applanation reading is low when the corneal thickness is below normal, and this can give a false negative IOP. Similarly, the applanation reading will be high when the corneal thickness is above normal. Thereby, the pressure that is shown high could be false positive, and we might be tending to start the anti-glaucoma medication without taking consideration of this corneal thickness. Thereby, if we have a consideration of this corrected IOP, we can prevent the patient from the unnecessary use of anti-glaucoma medication. Hence, calculation of corrected IOP in regards to central corneal thickness and monitoring its change could be a vital marker in acute anterior uveitis. Finally, the iridocorneal angle. Yes, the inflammation of the iris leads to the swelling, which can cause the decrease in the iridocorneal angle. Moreover, we definitely have the formation of synechia, either in form of posterior synechia, leading to the seclusion or occlusal pupillae that may push the iris forward, causing the iris bombae, and the peripheral anterior synechia can pull the diaphragm forward, leading to the shallowing of the angle. But if we can assess this on time, we can prevent from untoward complication. Thus, iridocorneal angle can be narrow in eyes with acute anterior uveitis, And if we are able to control the anterior chamber inflammation and release the synecia, this can lead to the normalization of the angle. Hence, monitoring of the itocorneal angle could be an important clue in the improvement of uveitic activity, and therefore should be considered another important biomarker for acute anterior uveitis treatment. So my take-home message is central corneal thickness measurement, the endothelial cell morphology study, and the corrected IOP measurement, along with the iridocorneal angle assessment, can be important biomarkers for evaluating the disease progression and treatment outcome in cases of acute anterior uveitis. If we ignore these biomarkers, chronic endothelial decompensation and long-term rise of pressure or fall of pressure can lead to irreversible uveitic complication. However, timely study of this biomarker can monitor the progression of disease and prevent from untoward ocular morbidities. I thank you for your patience hearing.
Thank you, Dr. Ranju. I think we'll go to the next presenter, Dr. Purushottam Joshi.
ऊपर का सबभन्दा माथि ऊपर का
present Minu. It's okay? Oh.
Good morning and namaste. My topic of presentation is TAS, Introduction and Prevention. So, in an uneventful cataract surgery, where preoperatively it was a right eye cataract surgery, 51 years male, no ocular and systemic comorbidity, uncorrected visual acuity 636, best corrected visual acuity 69, crystal clear cornea, very cooperative patient, fully dilated pupil, nuclear sclerosis grade 2 to 3. What we see in the first post-operative day is patient is comfortable with no pain, but on examination the visual acuity is 360, corneal diffuse edema from limbus to limbus, AC cells 3+, fibrin over the lens, hypopyon 1 millimeter, PCIOL stable and in situ, and fundus glow is plus. So we do not want this type of situation on the first post-operative day, and this is TAS. Toxic anterior segment syndrome is an acute, sterile, post-operative inflammatory reaction of the anterior segment tissues in response to non-infectious toxic substances. The term was coined by Monson et al. In 1992. Other terms for TAS are sterile post-operative endophthalmitis, toxic endothelial cell destruction syndrome. The clinical features of TAS are acute inflammatory process within 12 to 24 hours after intraocular surgery, inflammation mostly limited to the anterior segment, diffuse limbus to limbus corneal edema, fibrin formation, anterior chamber inflammation, and hypopyon. Gram stain and culture and PCR all negative for any microbial infestation. Clinical improvement is with steroid therapy. So we should always differentiate TAS from endophthalmitis, where in endophthalmitis it is usually after 3 days. There is severe pain in endophthalmitis. There is severe reduction in the visual acuity. There is much of vitritis in endophthalmitis. With steroid, the endophthalmitis worsens, but the TAS improves. The clinical course of TAS improves rapidly with the use of steroid. It depends on the type of toxic substance, duration of exposure, and timely initiation of the treatment. Severe cases, if not treated promptly, will lead to UZ syndrome, where the iris is damaged and won't dilate and constrict. Permanent damage to the trabecular meshwork cause ocular hypertension or secondary glaucoma, seborrheic bullous keratopathy, or epithelial downgrowth. TAS can occur after different procedures, not only cataract surgery, it has been reported to have occurred after vitrectomy with ERM peeling. There is association of TAS with IOP, TAS after intraocular posterior contact lens implant, reduced corneal density after TAS caused by intraocular ointment migration, TAS after pterygium surgery, barium contaminated IOL causing TAS, and TAS after aluminum contaminated and silicon contaminated IOL implantation. The major outbreaks worldwide have been reported from the most important was in 2013, where 251 cases were reported where intraocular lens was contaminated with aluminum. In 2015, 147 cases where heavy metal was contaminating the intraocular lens, and 112 cases in 2005 where the balanced salt solution had endotoxin. The renewed interest of TAS at the moment is because of the reporting of 41 TAS cases by the AOS members, specifically to the IOL from the CURE group, not proven, but they have went on to do the endotoxin level, which was less than 0.2 international unit per ml. So in the etiogenesis and pathogenesis, expected mild inflammation even after uneventful cataract surgery is expected, which is dependent on the duration of procedure and the amount of the intraocular tissue manipulation. TAS occurs due to the toxic substances entering into the AC during or immediately after surgery, breakdown of blood ocular barrier, and damage to the corneal endothelium. The most important agents indicated are the bacterial endotoxin, irrigating solutions which are not pH compatible, osmolarity, or ions, denatured OBDs, detergents in the sterilization process, and preservatives or additives to the ocular medication. Apart from the contamination, there are certain individual risk factors as well. TAS is more seen in patients who has diabetes, hypertension, hyperlipidemia, chronic ischemic heart disease, and chronic renal failure. One of the association has been plateletocrit value, whose plateletocrit value should be between 0.22 to 0.24. If more is seen, then TAS is expected. So prevention of the TAS is the key. Optimum ophthalmic instrument cleaning and sterilization process is a must. Written SOP, protocol for instrument cleaning and sterilization, regular update of the sterilization guidelines. We should follow the manufacturer directions for equipment cleaning and sterilization, devices, infusions, medications certified for intraocular use, where we should always check pH, osmolarity, ions, and it must be compatible. And endotoxin level should be less than 0.2. So
while sterilization and cleaning, there should be adequate flushing of the hollow devices. We should not allow it to dry. We should always keep it moist, and we should
clean it with distilled water, air, distilled water, air, distilled water till dry. We should be very careful while using intraocular and also even topical medications, and see whether there are preservatives, especially BAK or not. IOL wash before insertion, use of non-enzymatic detergents, and if MMC or 5-fluorouracil are used, a separate tray is to be kept and processed separately. And coming in a developing countries like ours, where we are using a single-use device multiple times doing ETO, from the point of view of global warming also, reuse is necessary, but and also cost effective also. So in European country, one phaco cataract surgery will cause an carbon emission of 180 to 80 kg of carbon emission, which is equivalent to driving a 688 kilometer petrol car. So if we do the principle of reuse, reduce, and recycle, then we can definitely be cost effective as well as helping the environment as well. The option for a hospital are to stop reprocessing single-use devices by themselves and outsource a third-party reprocessor who can do the reprocessing for the devices. But in our hospital, we are doing the ETO till the instrument equipments are working, like cannulas and all these. So this is an algorithm for prevention and investigation of the TAS, which was published in BMC Ophthalmology. They have elaborately detailed what to do and what to look for. And there are TAS outbreak, and there has been recall due to the intrinsic endotoxin contamination. In 2005, the Indosol Cytosol laboratory recalled all their products of the balanced salt solution. And in October 2008, of OBDs were recalled, which was produced by Hilon D. In April 2013, intraocular lens ICER Toric 351 and Toric 311 from Hoya Opticals were recalled. In 2014, Heidelberg
OBDs were recalled. In January 2016, Rayner intraocular lens Sulcoflex Tori were recalled. Most of them were because of the endotoxin level, whereas in this January 2016, it was
because of the increased aluminum level, suspicion of aluminum contamination. So take-home messages: there should be a written SOP protocol for instrument cleaning and sterilization. We should not allow any cannulated devices to dry till the cleaning station. We should keep it moist. Rinse, flush, air flush, completely dry it before storing. Oil wash before inserting into the eye. Follow manufacturers' instructions from the manufacturers. We should proactively ask for the endotoxin level from the manufacturer for any substances which are entering into the eye, from irrigating solution to OBDs to IOL periodically. Judicious reuse of single-use devices. As with all the cases of post-operative inflammation, endophthalmitis must be ruled out. So we don't want this middle path of the TAS. We want a clear cornea with good vision in the post-operative period. Thank you. And we'd like to invite you all to Kathmandu. There is going to be an annual conference of Nepal Ophthalmic Society from 22nd to 23rd November 2022. We would like to invite you all to that. Thank you very much.
Thank you, Purushottam Joshi, for your nice presentation. May I call upon Minu Chaudhary? She will speak on high order aberration and keratoconus. Minu.
Thank you, ma'am. I think I would like to thank the All India Ophthalmological Society and the local organizing team for calling us and letting us do this Nepal Ophthalmic Society session. So this topic, high order aberrations and keratoconus, is something which is not talked about much, and it is very important because it is actually affecting the visual quality of the patients who suffer from keratoconus. So first we should understand is what is this high order aberration. Actually, the human eye is not a perfect optical system, but it suffers from high order aberrations that degrade the retinal image quality. So light aberration is actually causing blurred vision. So there is this diagram which shows that if the surface of the cornea is not normal, or if it's thinned out, or if there is some problem, then it doesn't go and converge in one point. So it forms a blurred circle. So these aberrations are actually when the light from one point of an object does not converge or diverge into a single point after transmission through the system, and it forms that blurred circle. So if you see the classification, optical aberrations can be monochromatic or chromatic aberrations, but nowadays we don't follow the Siddle's classification. We normally follow the Zernicke's classification, which also again divides the aberrations into low order and high order aberrations. And we are basically, like, even if you have myopia or hyperopia or even astigmatism also, you will have some kind of low order aberrations, but that does not really cause so much of problem, because we can actually correct it with spectacle lenses. But high order aberrations in the form of spherical aberrations, coma aberrations, and other high order astigmatisms are again very important. So normally we follow this Zernike's polynomials, where you see that the first order are the ones which are in the higher side, which is basically the aberration caused by astigmatism. But then if you go to higher order aberration, which is on third, fourth, and the fifth line, where you have the coma, which is the vertical coma, and the horizontal coma, the trefoil, the quadrifoil, and the spherical aberrations, which are very important. And these spherical aberrations are actually depicted as point spread functions, which you see when you do an aberration. And I don't think I'll go much into detail. So this is again also a slide showing the point spread function, like when the light moves from the corneal surface. So actually these aberrations are a function of the corneal surface or the corneal topography, not something that is going on inside. And then it forms an image where it can be in the form of coma, the trefoil, or the spherical aberration, and you can see that as a blurred image. So this is how the image degradation happens when you have the aberrations. And how are these aberrations actually measured? They are measured with the help of aberrometers, and you have a commonly used technique, or the method is the Schack-Hartmann method, where in which a bright light of beam is projected into the retina and then it gets reflected back through the eye. So this is just a photograph showing the Hartmann-Schack aberrometer. And I think now what are these symptoms of high order aberration? Because in keratoconus now this is very important, and because keratoconus is actually by the like the children, so they don't actually know what is happening. So they may complain of glare, blurring, double vision, lack of contrast, reduced color perception, starbursts, halos, and even decreased distance and near vision. But you should also take into account the pupil size. The size of the pupil is also going to cause some amount of aberrations. So keratoconus, like we all know, it is a progressive disease which may affect one or the other eye later on, and there is corneal thinning and protrusion, and that leads to reduction in the optical quality of the eye because of the corneal distortion, the scarring, and high order aberrations. And like what I'm saying, actually the high order aberration is not the function of the retina, or the post-retinal neural aspects are all fine. It's just the corneal surface which is causing all the problems. So we all know by the time in our countries the patients come to us, they have Vaux striae, or they will have monsoon sign, or the cornea is very thin because of the thinning of the cornea leading to the cone. You may have patients where they have scars. But it is very important that you actually pick up these keratoconus patients in the early stage when they're complaining, or you have to go for these topographies, which is now mandatory, at least for patients who are coming with inflammatory diseases, VKC, or even people who have predispositions, especially in the siblings, you should do that. So the keratoconus patients will come with coma, in which they will complain of double vision. They may have trefoil, where when they say, how does an image look, it looks something like how the Mercedes-Benz Swimble looks like. I'll show you the photographs. And spherical aberrations, if they have spherical aberrations on aberrometry, they may complain of halos, starbursts, ghost images, or lack of contrast sensitivity. So now it's very important to see for all this. See, this is how a ghost image actually looks like. So when the patient comes to you, you have to ask them, do they see another second image or a ghost image next to the normal image? See, when you see, it's not clear. So this is how your child or the keratoconus patient is actually seeing. See, this is how now you have an halo. When you see the car lights, especially if they're driving, in our countries also, even the children start driving. So it's very important to ask them to see whether they see the lights like that. This is a very important, these photographs are very important for how they may see things. So now these are cases, I'll show you some of the cases where, like when you have a keratoconus, you have a cone which is dropping down. So once the cone is going more inferior and more inferior temporally, you start developing a coma. So when you have this high order aberration in the form of coma, now they will have these symptoms of high order, like I said, double images, glare, halos. So it's very important to do a topography, and you have to do an aberrometer. So when you do these aberrations, you can see the low order aberration is about 3.45 and the high order aberration is 3.39. So I don't have a pointer. Do you have a pointer? So you can see that actually in the second row, if you see, the second picture, that is a vertical coma which is about 2.81. So that is quite high. So as the cone, as your thinning and the cone is moving down, you develop more of coma. So these are again some of the photographs. See where you see that the low order abrasion and the high order abrasion is, the high order abrasion is, it's not coming. Pata nahi. So the high order abrasion is nearly 8.53. So as your cone and your cornea is thinning down, your surface is becoming more, curvature is increasing, it's becoming more steep. See, the more the high order abrasion is increasing, and that also leads to increase in the spherical abrasion. So these are the photographs of cases where you have the topography, where you can see that there is the cone. So this is the cone, this is the posterior elevation. So now this is a photograph. See, it's very important that whenever you have a patient or you suspect a keratoconus case, please do a topography and please do an aberrometry map. See, look at these images, how they see. The high order abrasions are increasing. And as the high order abrasion are increasing, if you see the graph on that side, which is red, you see that the reference green color is decreased, and the white and the red color is increasing, because that shows that the steepness or the curvature is increasing and the high order abrasion is increasing. So these are again, this is again a case 2 where again your cone, the posterior elevation is increased. And as see again here, look at the image. The image, that is how the point spread function, that is how the high order abrasion is increasing and how the patient actually looks at. There is no green, if you see the map on that side, there is no green color actually. It's all black. So that shows that the surface is so aberrated, or it is so, like there is so much of problem with the surface. See now, this is again this case 3. Same thing, the topography, you have a big cone there which has shifted inferotemporally. So how do you actually correct these things? They don't actually get corrected with spectacles. You have to go for adaptive or customized lenses. Even normal lenses, contact lenses don't work. You can go for RGPs. But the best thing is to use the customized or the adaptive lenses. So this is, like I said, it's with these adaptive lenses. And I think I'll show this last picture. This is one of our case. See, if you see, the high order aberration is so high that the point spread function, there is no green color as the reference color on the slide on that side, and you only have the black color. So this was corrected with scleral contact lenses. See now, at least the blue color has come, the green color has come, and the high order aberration has decreased to minus 1.91, whereas initially it was 29.90 if you see above. So it's very important that you correct and see the visual quality of the patient is very important. Otherwise his school performance, or most of the times initially I remember they used to be diagnosed as amblyopia, because that time we didn't have topography, we didn't have aberrometries. So it's very important that we diagnose, and many times the children will not complain, so we have to ask them, do you have these problems? And these maps are very important. So in conclusion, I would like to say that, see, keratoconus patients suffer from high order abrasion. It affects their vision and their quality of life, and it is actually a surface problem or surface irregularity. So corneal topography and aberrometry can help in early detection of keratoconus, and the treatment is with contact lenses, but the best is customized or adaptive lenses, which are still lacking, but still we can try with these scleral contact lenses. Thank you all, and I would, as president of Nepal Ophthalmic Society, I would like to call you all for our annual conference, which will be held this year in November 22nd and 23rd. So please come, we welcome you all for our annual conference. Thank you so much.
Thank you, Minu, for your excellent presentation. Now the question and answer session. Any question for any speaker? No question? I have a question to Sanyam. Yeah. As retinal detachment, you showed in your second case there is myopia. and there is a giant tear also occur. What are the causes of this case? How does it occur? Any trauma? Microphone? Any microphone? You come here. Sanyam, you come.
Vitrectomy in other center before coming to me. So the possibility is retinal tear because of vitrectomy done in the other center, or it's probably a myopic large retinal tear also. So both possibility. So he had a surgery before coming to me.
How
The
much
first.
diopter myopia?
He was -5 diopter.
Minus 5
Yes.
diopter.
So that could be, both could be reason, but I don't want to blame the other institute. So probably it's a myopic detachment and with a total vitreous hemorrhage.
And in your series of retinal detachment, how much you get this myopic retinal detachment?
We see almost 15 to 20% of detachment because of high myopia. But most of our detachment are pseudophakic retinal detachment, aphakic retinal detachment, and if there is any complications on previous cataract surgeries. So I would say the primary regmatogenous retinal detachments before cataract surgeries are definitely a myopic, high myopic RD.
Okay, thank you.
I have one question for Dr. Purushottam. Since you are working in a very high volume cataract surgical center, so definitely in high volume cataract setup, there will be definitely the number of complications will be more, so it will be more highlighted. So if you get a task, I mean, if you get a kind of hyperpine in the first postoperative day, if you get more than 5 patients in a single day, and the clinical picture will be different, right? Some may have a hand movement, some may have a 6x60. So what will be your line of management for those, the cluster endophthalmitis, or it will be task first day, right? So what will be the line of management? How will you suggest for those, high volume tasks?
The task which we had, usually it's like this: the same surgeon, the same assistant, same OT table. One has task, one doesn't have. It occurs like that. So in that case, in particular from patient point of view, we give subconjunctival dexamethasone, and in the OT we re-sterile everything, and we again redo it. We change the BSS, the batch number. We now put the batch number of every BSS and OBDs. We change everything, and we continue with the other one. No, we don't stop the operating room. Yeah, we don't stop the operating room. Luckily for us, it has resolved with the steroid only.
Okay. I have a question.
I think, just one.
Please.
Normally what happens in TAS, the corneal problem is it's very different from what is it in endophthalmitis. And even the limbus, so it's very important to first look at the limbus and the cornea, because it's actually toxic anterior segment syndrome. So you can actually say, and like what Purushottam is saying, whether it is from your BSS, whether it is from your gloves, so a pattern will be seen normally. So you can actually identify. It's not that you cannot identify it as. Sir, please.
Actually, from the public health point of view, if you do the high volume surgery, that's mean how many surgery you are doing in per sittings, per hour?
Per hour. Per hour, maybe, it depends. If SICS, it's maybe 15. If FECO, it's about 10 to 12.
10 to 12. Then, did you follow up those patients through the impact of the surgery?
Yeah,
because you have to increase the CSC. CSR is not the main
Yes,
issue.
yes.
Just for doing the high volume surgery, you are increasing the CSR. But what is the CSC?
Yeah,
did you do the impact of that?
the CSC is CSR is more than 4,000,
Yes.
but CSC is for single eye it's 72%. For bilateral it's 57% only.
57.
So we are still lagging behind.
That's the big challenge for the high volume surgery, because if you don't have a high quality
Quality.
surgery,
Yes.
then CSC is always low. That is very important. So thank you very much.
That
Thank
means quality surgery should be there to cover the cataract surgical coverage.
How much is it in Bangladesh, sir?
In
Bangladesh,
we
yes.
do some high volume surgery as a pilot.
Okay.
Particularly, we are not doing it routinely. There are some pilot we did in some area, particularly in Sylhet area, and that was also 15 surgery per hour, but the CSC is again challenging. So nowadays we are not advocating the high volume surgery, but we need to do it because we have a big backlog. Still there are 600,000 backlog in Bangladesh. So we need to do it, but the question is this, but we could not evaluate regularly. The question is we should have evaluate regularly to see the impact after the surgery. That will give you the opportunity.
Yes,
Okay,
I think
thank you so much.
CSC is not related to the quality of surgery. Lower CSC is related to the inaccessibility of the patients coming to us.
I think time is very short. I would like to thank all the speaker here. There are 5 speakers: Srijona, Sanyam, Ranju, Purushottam, and Minu. Everybody did very well, and some question and answer also satisfied the audience. So I would like to conclude this session, as because there are other sessions. Before that, Minu, please say something.
We'd
I
like
have
to.
another session now.
Yes.
I will
Thank
go.
you, ma'am, so much. She is one of our most prestigious chairperson today because she is also the APO, our chairman, and the president of APO. So we'd like to thank her for taking out time for this Nepal Ophthalmic Society session. We'd also like to thank the audience to be part of us. And please come for our conference, and we'd like to request all the speakers to have a photograph with
Oh,
ma'am.
right.